Hello, dear friends. How are you? I hope you're all continuing to do well, staying well. I'm Mark Golub. It's always wonderful to be with you as we all try to live in these most difficult and trying times. And it's been quite a week celebrating Israel's 72nd birthday. And the day before, commemorating Yom HaZikaron, the Day of Remembrance, a sort of Israeli Memorial Day. And isn't it amazing how people are being so creative with the use of Zoom and other video programs so that people are finding ways to still be together, at least on screen, celebrating together. And I hope the programming we provided for Yom HaShoah last week and Yom HaZikaron and Yom HaAtzmaut this week helped you feel part of the Jewish community for all of the events of the past almost 2 weeks. And thank you to all of you who've sent me lovely and appreciative emails during this period of time. All of us at JBS are moved by your caring and by your very kind words. So really, thank you. Well, we continue to struggle as a society with the coronavirus. We're learning bits and pieces more about how the virus operates. There's no question that it's very easily communicable. But it also seems that it's less deadly than it was once thought to be. And that's good news. But there's never enough information. So on this edition of Gam Yachad, Together During COVID-19, I want you to hear the second part of my conversation with Dr. Howard Werman, Professor of Clinical Emergency Medicine at the College of Medicine at Ohio State University, and an attending physician at both the Ohio State University Wexner Medical Center and Ohio State East Hospital. He has some fascinating things to say, and I hope you enjoy listening to him. Here is Dr. Howard Werman. Howard, thank you again for joining us on JBS and giving me the opportunity to ask you a million questions. Thank you very much. We spoke in our first conversation. We spoke about the ways in which the coronavirus is communicable. We're told, Howard, that this virus is more communicable than other viruses, such as influenza, which can take, and influenza can take the lives of as many as 50,000 Americans in a given year.
Right.
Can you explain to us what makes this virus, the coronavirus, more communicable?
Part of it, I think, is just the characteristics of the disease, the fact that it's potentially a little more fastidious, if I can use that word. It's a little bit more hardy than other viruses, than even the influenza virus. So we've just talked about the fact it will stay on surfaces a little bit longer than the flu might. It is more easily transmissible, say, in the air. But probably the most important thing is that we are, this is a novel virus. Our body has not seen it again, never seen it in the past. So we don't have a vaccination, which means that we don't have a vaccine, in other words, which means that the entire population is eligible to come down with this. I mean, when we do flu vaccinations at the beginning of the year, that means that's that many people that cannot become infected with the virus. So that reduces the transmissibility.
Yes, but in all honesty, that does not speak to the character of a virus. The fact that we may be immune from because of a vaccine says nothing about the nature of the so that I don't want to conflate those two issues. The issue, and you began by explaining, I thought, very well. You said in some way this virus is, and I think you used the word hardier, or it's stronger. It seems that what you're saying is viruses last on surfaces for different lengths of time. And for whatever reason, this virus, the coronavirus, lasts on surfaces for a longer period of time, and that would make it more communicable because more people might touch that same surface. Do I have it correct?
Yes. So they even do statistics on this. And I think if I remember the statistics, is on average, a person with the flu will transmit that virus to about 1.3 other individuals. So the coronavirus, again, before we started socially distancing, the number was about 2.7. So again, if you think about that, if you look and think about, well, how often does another case appear? And then how often, how many people get that? So if you take, as we might have, let's say you start with one person, in 5 days, now you've got close to 3 people. Those 3 people in 5 days transmitted to 3 others, and you can see how exponentially it explodes.
I understand. By the way, that still is a slightly different dimension of the same problem.
Yes.
Because again, the question is what makes this more communicable, and then lo and behold, if it is more communicable, what happens is people who have it give it to more people. That I understand.
Yeah.
But it's what you said at the beginning that is critical. Why it is more communicable. Bottom line, it's a more virulent, longer lasting, stronger virus that can be present for a longer period of time than other viruses. I assume, Howard, for example, more so than influenza, correct?
Yes, I think that is true, the characteristics, but again, it's a function of all those things. It is a function of prior immunity. It's, a function of, the measures that we put in place too. But again, on its surface, it seems to be more transmissible, and that at its baseline is probably related to some characteristic of the virus itself.
Do you, but I really mean you're part of this medical world. Does the medical world, as far as you know, understand how long the virus, a droplet of this virus, would live, for example, on cardboard or on the kind of material that UPS uses or that Amazon uses when it sends a box or a package to someone's home? How long does it last on that kind of surface? Do we know?
So I'm going to give you a hedged answer. The answer is that we do know how long, because they know they can grow it off of surfaces. What is unknown is what's the threshold of concentration of that virus, what's the virulence over time that means that that person could come down with an infection based on that. So I don't know if that makes sense, but that means you might be able to grow some virus on a piece of cardboard, but that concentration or that virus that's on there may not actually be infectious at all.
Okay, you already told us that if people are sitting outdoors, socially distancing 6 feet or more, as far as you understand, there is no danger to them, and that people basically should try to find those kinds of ways to have social intercourse while having social distancing.
Yes.
I want you now to be as helpful as you can be.
Sure. For
questions like, okay, a package is delivered by Amazon in your home.
Yes.
What do you do? What does your wife do? What would your kids do to accept that package and stay safe?
Well, first of all, it would be, number one, it should be dropped off, in front of the house. So it shouldn't be handed to you directly. The folks, frankly, that are working these days, and again, I don't know, I can't vouch for what's happening inside FedEx or Amazon or any of those, how socially distant and how protective they're being, how often they're cleaning surfaces. But the package should be placed outside of the house. You don't have direct contact with the person delivering it. And then literally what you do is you can handle the package. But as soon as you're done handling that package, you go and you wash your hands, again, clean yourself and make sure that in the interim, you don't touch your eyes, your mouth, or your nose. That's the safest way.
Okay. You don't have to wipe that package down with some kind of disinfectant?
I don't think there is any recommendation to do that.
All right. How about on metal and on doorknobs? How long does the virus last on a doorknob so that you either are or are not frightened to touch a doorknob?
So again, that's another one. It can last on there for sure, and I can tell you my own experience. The first thing I do when I park in a parking garage when I go to work. And in the interim, I have to probably open 2 doorknobs to do so, where visitors and patients are coming in and out of the medical center. The first thing I do when I get inside the medical center before they take my temperature is I wash my hands completely using an alcohol. And I'm cognizant of not touching my eyes or anything like that.
I appreciate the answer,
Yeah.
but I want to push you again.
Yeah.
I understand. You're saying to yourself, I'm going to be cautious. I will err always on the side of caution, meaning as soon as I come from one place to another, touch anything, I'm washing my hands, and I'm certainly not going to touch my face, any part of my face, before I do that. But that wasn't the question. The question is, do we know if, for a fact, no one had touched that doorknob for an hour, for 3 hours, for 6 hours, since the night before? Is it possible if somebody the night before touched, coughed, sneezed on that doorknob, is it possible when you arrive the next morning and get out of your car that there is still a virus on that doorknob which could spread this virus to you if you did not wash your hands and you did touch your mouth? That's the question. How long does it last on a doorknob?
Here's the thing. I will tell you that specific question, I don't know the answer to it, but it is known. It is known how long the virus can be detected on surfaces, whether it be cloth, whether it be cardboard, whether it be metal. That information is out there. Now, the thing that they don't know, again, which I come back to, is that they can detect the virus particles. What they can't say is where is that threshold that it is potentially infectious or not.
In other words, there's a volume involved as well, right?
Yes, yeah.
Okay.
So again, it is, people can find that. There are studies that have actually looked at that. I personally don't, know, and that's why I just advise people, anytime you touch a surface like that, I am so cognizant, when I get into work and bring in my bag that has my equipment and stuff, of the surface I'm putting it down, I need to wipe that off. Now, the other thing, too, that I do want to say about the virus that we have understood is that it's not so fastidious that it isn't cleaned by the usual. So, basically, if you're taking a bleach wipe or something like that, those things are very effective at cleaning off the virus. So that we do know.
And what about just plain ordinary ivory soap?
Soap on your hands?
Yes.
Yeah, again, if you're with hot water, washing as they recommend for 15 to 20 seconds, that seems to be effective as well. Not to get into too much detail, but I will tell you that, each one of us as physicians who work in the environment have our own specific routines that what we undertake when we come home, to make sure, actually probably the most dangerous part of what we have that we wear is our shoes. Believe it or not, the shoes are contaminated because the virus, if it's coughed, even if it's airborne, it ends up settling in the ground. And for those people who literally go in and do some of the more dangerous aerosol generating procedures, they'll even take the precaution of wearing boots or shoe covers or something like that to protect themselves. But in general, it's recommended that your shoes should not be traipsing into the house. So I leave mine at the doorstep. I'll usually take my socks off as well. I will go immediately to my laundry room. I shed all of my clothes there right into a hot water cycle. Some people have even recommended doing 2 cycles. I haven't gone to that precaution yet. And then the first thing I do is hot shower where I'm using soap and water for a good, 15 minutes.
Fascinating to hear.
Yeah.
You're very helpful. By the way, how many people are in your own home?
Well, fortunately, it's just my wife and I.
Okay. Were you ever worried that she would get the virus from you?
Yes, it's still a worry because every day I go, at least through an area, if not, just to be fair, yesterday I practiced for 6 hours in the area that we probably have most of our, at least where we put all of our COVID or suspected COVID patients. I personally came in contact with 3 or 4 people who had cough and had sore throat. I'm lucky to say that none of them tested positive. At least in our rapid testing, they were not positive.
Mm-hmm. You said you had to be tested twice. I'm told that if a person is tested and comes out negative, roughly 30% of negative tests, negative results, could be false negatives, and that's why a second test is necessary. Is that why you were tested for a second time?
So, no, my second, and actually let me clarify, I was tested 3 times, and I'll tell you why, and it might lead to an interesting story. The first time I was tested, the test was not being run at the medical center that you see behind me at Ohio State. It was actually sent out to a lab which was in North Carolina, and they were inundated. At the time, I was told that the results may take as long as 5 days, and that would have put me on a Wednesday to get the results, and I would have gone back on Thursday to work if it was negative. Unfortunately, the result never came back, and when I brought that up to the folks who were supervising me, they said, well, we're running the tests in-house starting on Thursday, so let's do the test again, and we'll add it to that lab. And frankly, it wasn't until Friday that I actually got the result that I was positive. Now, the interesting thing, going back to your first point, my original test, which had been actually taken 5 days earlier, came back negative. And as I now know, again, since I have had antibody testing, I do know that that was a false negative test. And that was the PCR test, which was at the time the most sensitive. Now, the problem that we have currently, the only way we can really understand the false negative rate is to go back historically and look at SARS, because the SARS virus and the current coronavirus, in fact, you may know that the other name for it is SARS-CoV-2, because it shares about 80 to 90% of the same genetics as this new virus does. In those days, they did identify a false negative rate of between 25 and 30% when they actually had a definitive test. We don't have a gold standard that says, a culture or, something that says that you definitely have had it. Or at least we're not doing that kind of test. But we assume that, and again, clinical experience teaches us for people who have been, who have been tested, that there is a false negative rate.
I understand.
Why did I have a third test? One of the experimental therapies is to give what's called convalescent plasma to patients. So you take somebody who was known infected, had a COVID positive test, and presumably has antibodies, and you give those antibodies through the plasma, the liquid part of our blood, to a patient who has not yet developed their own immune system or their own immune response, in a hope that their immune response will kick in. And I've donated plasma twice under those circumstances.
Very, very nice. How effective do you think that is as a treatment for people with COVID-19?
Don't know. Those studies are currently being undertaken right now. So we will know more. But it is, convalescent plasma is not a new idea. It's been used, in diphtheria, in Ebola, in other situations as well.
Right, and that's why I understand the medical profession hopes that the antibodies that a person can donate to another through plasma will be in some way efficacious, yes?
Right.
Yeah.
Now that, again, is a whole other issue, which we don't know. We don't know if the antibodies are effective and at what titer, in other words, what concentration they are effective. I've been told I have titers, but my titers are relatively low. So am I safe? When I go to work, I presume I have no antibodies. I do the same things that the person who has not tested COVID positive. Do I think I probably have some protection? I think the answer is probably yes.
I understand. So how overwhelmed have your hospitals, Ohio State University, Wexner Medical Center, and Ohio State Hospital, how overwhelmed have they been by a rush of coronavirus patients?
So it's very interesting what's happened to us. First of all our overall volumes have shrunk. We probably, at our nadir, we were seeing about half the number of patients that we were seeing before the coronavirus epidemic. Now that's total patients. On the other hand, more patients came in with concerns of coronavirus and, or documented symptoms of coronavirus. And so, of the patients we see, a good percentage of them at least have that concern. They're the patients who have all of a sudden they have a sore throat, they've got fever, they've got cough, they've got body aches, things like that. And we're testing a lot of...
But they don't have COVID-19.
Again, probably between 10 and 20% of them end up having them. Now, I want to make a couple...
Excuse me for one second. Yeah. So what you're saying is a person with cold-like symptoms, flu-like symptoms, 80% of the time, even if they have those symptoms, they still do not have to think they absolutely have COVID-19. 80% of them are likely not to. Did I get it right?
Based on our testing, the answer to that is yes. Now that may not be true in Queens, New York, or places like that where they have a much greater outbreak. So the point I was going to make is we are lucky in Ohio because our governor literally saw this coming down the pike and really instituted measures. At times people thought he was crazy, but we had a big gathering called the Arnold, which is a big health and fitness expose every year here, brings in 60,000 people from all over the world. And that happened, I want to say that event was scheduled sometime in February, mid-February. And he got together with the health director and they decided we are not going to do that this year. This is just not safe. And that was the beginning of their response. They canceled schools early. They closed businesses relatively early. And so Ohio has really been sort of lucky in regards. Now that's in the general population. And I'll add a caveat to that. Unfortunately, one of the areas that wasn't well thought of, and frankly, I'm not sure much could have been done, we've had an epidemic in a couple of our prisons. And that has been a big issue. At one point, we actually went out and tested an entire prison facility and the corrections officers at that facility, and about 75% of them tested positive.
Wow.
So you've got the whole thing twisted on its head. You've got the healthy people being quarantined from the sick people as opposed to the sick people being quarantined from the healthy people.
Yeah, there are many very complicated social issues that this virus has brought up.
Yes.
Do I gather then you always had enough beds and you always had enough ventilators?
We still do. Yeah, we're tracking that both as a state. We have a very active region in Ohio. Columbus is the catchment area for about 2/3 of the state, going, again, between Cincinnati and Columbus, Dayton and Columbus, Toledo and Columbus, Cleveland and Columbus, and then the entire southeast, almost to West Virginia, is all, the catchment area for Columbus. So,
Howard, what about medications? We've heard a lot about hydroxychloroquine. We've heard now about a new medication by Gilead. I think it's called remdesivir.
yes.
What is your sense of the efficacy or the possibility that either of those medications, those drugs, could be something people with the virus could take to avoid getting really, really sick and to avoid dying?
I would say at this time, we don't have a magic bullet. We just don't now. The studies I think we're getting some data on hydroxychloroquine, and I think those reviews are mixed at best. There was just a study from the Veterans Affairs, I think, and it actually showed no clinical difference in the amount of people who ended up on ventilators, and actually a higher death rate in the group that got the hydroxychloroquine. But still, that's a small study. We need bigger studies on that. There have been some combination antiviral agents that have been used for HIV/AIDS. That doesn't seem to be panning out. I think probably the you said it before.
Remdesivir.
Yeah, that medication, we don't know yet. It's showing some promise, but again, we await the results of trials. Certainly we're going to have those results because we have so many cases. And then the other one is, the convalescent plasma, which is being studied as well in a number of academic centers. And so we'll know more about this. Unfortunately, this is all, they're all stopgap measures. What we really need is a vaccine.
Howard, the numbers keep being revised down.
Yes.
Why were the models that we were using at the beginning, why have they proven to be so wrong? And is this pandemic less of a threat than we earlier had assumed?
I don't think it's less of a threat. I think that what it's proving is the really value of and importance of the measures, and the draconian measures, unfortunately, that had to be undertaken to get this thing under control. We've talked about it. The virus only lives is only transmitted if you're doing the kind of things, touching surfaces, close contact, things like that put you at risk. If you mitigate those things, then it's essentially the same thing as what happens when you vaccinate people. You can't transmit it to somebody who already has those antibodies. You also can't transmit it if physically you're not next to those folks. So I think it speaks to that. I think most of the early models talked about what would happen in the situation where we were not implementing those measures. Unfortunately, now we're into the debate about, how do we balance the mitigating health risks versus the economic consequences of
Absolutely.
those.
A huge issue.
It's not easy.
And, for that matter, this is not your area of expertise, nor is it mine, but you're a thinking, feeling person, and you're a doctor. And you want to save lives, and at the same time, anybody with a brain now sees that the extent to which we have shut down the economy and society, mainly the economy,
right,
is having draconian effects on people's lives.
Yes.
People may actually lose their lives because of the fact that either they can't support their families, they don't have money, they're depressed, they've lost their businesses, and that, as I said in the very, very beginning of our discussion, we may never see the world again as we've seen it before the coronavirus became a reality. So I'm asking you, how do you feel right now about those who are encouraging a layered approach to reopening society and restarting the economy?
I think there's some reason to it. I mean, I do. As we said, even as we look, I think if you look at how we responded a month ago as individuals and how we are responding today, people are out there walking, they're maintaining social distance. I think all of those measures, the way that going to a restaurant will be different is you may not be packed one next to each other. Every table may be cleaned in a different way than we're typically doing it now. You may have to wait on a line at a bank 6 feet away from the next person. There may be, alcohol, cleansing agents available much more widely than in the past. But as you said, think about 9/11 as I always use this example. Do you get on a plane the same way that you did before 9/11 now that it's been, 19 years or something since that happened? Do we do things? No. So we will probably, life will be very different. And by the way, let me make one last point.
Sure.
This is not going to be the last virus like this we see. This isn't, yes, it is a once-in-a-lifetime thing, but the people who look at these things understand that there are other viruses. There are, flu strains, frankly, that potentially could produce a pandemic, not quite on the order of this, but certainly could be devastating.
Yeah. There are also people who are worried about what's called the second wave, that even if things look good as we head into the summer, there's a fear that when the fall comes, the coronavirus could return. And the question is, will it take more lives than it did the first time, or will we have to once again huddle back in our homes? Do you have any sense of this idea of the second wave?
I believe that we will see further cases for sure. One of the things I think is, something we know is that most viruses have a seasonal component to them. We know this for, our RSV, we know this for flu. So we may see a natural taping just based on, the summer heat and I can't really explain why that is, but it is just a fact. The flip side of it is it will probably still be around because, some people will still be naive to this virus. And there will be sporadic cases. How we respond to it is, it depends. It depends on how bad that is. One of the other things, again, that was mentioned and brings up a little bit of controversy is it synergistic with flu? We know that flu is going to come back in the late fall and, early winter. How do those two interact? Things like that. So I don't know. I think, some people think it might be, less devastating. Some people have said it might be more devastating, depending on, again, whether they're synergistic. I can't really say based on that. But I think we should be prepared for it.
And so when you talk to your wife,
yes,
and how many children again?
4 children.
You talk to your 4 children, and they have children?
My 4 children, yes. I have 8 grandchildren.
Mazal tov. How lucky are you? So when you talk to your adult children,
right,
do you say to yourself, and you say to each other, the reality is we're going to have to stay home, and that we're going to have to figure out some other way to start the economy. I don't want you, my 4 children, and since they have their own children, we're talking about your adult children. Do your adult children, who are not 60 or older,
right,
do they return to society with the precautions that you've mentioned? And you're reminding us that we do not get on a plane now the way we got on a plane before 9/11.
Right.
And it may very well be we will not go into a restaurant the way we did before coronavirus, but maybe we will go into a restaurant. Maybe your 4 children will go out to dinner. They'll just go out to dinner in a different form, Maura. Mm-hmm. They will not be in as crowded a restaurant, or as you say, they may have to do certain things before they enter and when they leave and how the tables are. But they will be out, and will they ever go to a movie theater? And maybe the movie theater will be reconstructed so that people will not be near each other. Will they ever go to a ball game again? Will they ever go to an indoor? Will they ever go to a basketball? Will they ever go to a concert again? Will they ever? And will their children, will your grandchildren go to school and sit in a classroom? And will they do that in September when you've just told us it could be that there will be a second wave in the fall? So I've asked you a whole bunch of things, but they're all the same kind of question. At what point, Howard, are you comfortable with your wife, who's at one age group, your adult children in a second age group, your grandchildren in a third age group, reemerging from their homes, and the society begins to once again function in as normal, if it could be different, but as normal a way as possible? What do you say to each other, and what do you think about this personally?
Well, here's the thing. I will say that the separation by age groups, although you are correct in terms of vulnerability of the disease and the potential for severe disease, is very different among those three. We are all intertwined, okay? So if my child goes to daycare, and I know, really the number of children, less than 14, who have contracted bad disease and have actually succumbed to this disease is minuscule. So were they to be able to stay in that, group, I would have no problem with that. Frankly, even today, they likely would end up getting a cold, and that would be it, if that was the world that they lived in. But they also come home to their parents, and they also interact with teachers, some of whom are in that 60. So unfortunately, the answer is, what we do, we have to assume we are doing for the most vulnerable of people who are involved in this disease. So with those in mind, we have to set the proper precautions. So if my son goes back to work or they go out to dinner, they've got to think about when they come back, how are they sanitizing themselves so that they don't, when I come over to visit, that I'm not put at risk that way. Same thing, if I see my grandchild, what have we done, the two of us, to make sure that something that he may be carrying asymptomatically or maybe a little bit of a cold is nothing more than a summer cold and isn't COVID. But again, we're going to, I think, have to dip our toe in the water and see what things we can do safely, and obviously then follow what happens to the population, and then take the next step and the next step. Unfortunately, I think that's the way it's got to be done for us to be protected.
All right, I'm going to make a suggestion.
Yeah. That
in some way, again, this is not in any way a criticism of you. The problem is this is such a complicated issue that things are often conflated.
Yeah.
So I'm going to respond to you.
Okay.
Nobody 60 years or older should be teaching in school.
Right.
Nobody 60 or older should be leaving the home until there is either a vaccine or an absolute medication of some type or a plasma, whatever it is. Unless we know somebody who is 60 or older is safe, they should not be commingling with your children or your grandchildren.
Right.
And so I want to use your model. We now fly differently than we once did. Well, you know what? We'll send kids to school in a different way, and we will now only allow teachers who are in an age group that makes them virtually, not 100%, nothing 100%, but they are in a minimus group of danger. Right. They're the ones who are teaching. And you know what? Right now, you won't see your grandchildren. Well, you still won't see your grandchildren.
Right.
So in either case, the worries you have were not relevant to the question, do we allow kids going back to school? Mm-hmm. What is relevant is your earlier comment, whatever we do, it's going to have to be done in a different way.
Yes.
And it seems to me that I personally, boy, I'm not leaving my home. Howard, until I get a phone call from you, you've got a vaccine,
right.
I'm staying here. That's just the way life is.
Right.
My wife and I are here.
Yeah.
Our children are elsewhere. We don't see them. We see them all the time on FaceTime and on Zoom. And I miss them. And I miss hugging them. And I miss their being in the same room with me. And we go on vacation every summer together. I don't think we're going to be able to go on a vacation together this summer. And I'm not going to do anything that's going to put my life in danger or anybody I love in danger until it's safe. The question is, are there sectors of our society which we can release that can become active again, that can become economically productive again, while at the same time saying to anybody above a certain age, sorry, you're not safe and you have to stay home. And, you know, Jacksonville, Florida took an awful lot of heat, Howard, as they're opening up. Mm-hmm. And Jacksonville has less than 1% fatality rate from coronavirus. Right. And they're saying if we implement all the things that Howard would implement, we socially distancing, and there is ways in which we sanitize wherever we go. Why shouldn't we let people go on the beach? And why shouldn't there be a masseuse and a person getting a massage? That's not a group of 20 people. It's one-on-one. And yet there was this enormous criticism of Jacksonville, Florida, that there's going to be a spike and they don't care about human life. And none of that seems to me to be rational. And I hear the way you describe it. Mm-hmm. And it seems to me that if people listen to what you're suggesting, although it would only be, and I use this word again, a layered return to life and the economy, a layered return would not be irresponsible and would continue to keep your children and your grandchildren safe. Tell me if I've said something that resonates with you or you disagree with me.
No, it definitely resonates. I mean, obviously there are some things that you have to think through with that, of course, which is, I mean, given our population and our the cohort that's 60 and older can be a very productive cohort. And I would add a caveat to all what you've said, and we need to understand more of this. We do not have widespread antibody testing, which, by the way, I mean, some people have said that, hey, I'm 65 years old, but I've got a certificate. It says that I have antibodies that are protective. So in theory, were I not personally in the healthcare profession, I, in theory, could visit my grandparents with my grandchildren and my children with impunity because I'm not going to get the disease from them. I'm the group that we worry about because, again, my particular cohort, our fatality rate is higher than 1%. It's in my group, it's probably 3%. And if you get up people in the 70s, it's probably 6-7%, and up to 14% above, 80 and higher. But, again, the solution you raised is certainly an appropriate one, given the mitigating, factors until we get a vaccine.
Again, I think you said very, very well. How long is this going to go on? Howard, there are people who are worried there will never be a vaccine. And do you ever say to yourself, the sad reality, the tragic reality is that ultimately the only way we are going to deal with this is by recognizing that society must again function with some degree of normalcy. It may be a different kind of normalcy, but in some degree of normalcy. And at the same time, there will be a certain number of people who will get sick. Some will get very seriously sick, and some will die. And that's part of any social construct. There are things that right now people die from in America all the time, and we have made social policy that says the balance, as tragic as it is, and again, if it's your family member, it's 100%, and it is 100% tragedy. But that's not how social policy is created. Social policy says we look at society as a whole, and we make the best decision and the kindest decision and the most humane decision we can to protect as many people as we can, knowing that a certain number of people are going to die from the flu. We make a decision that we will create automobiles that have the capacity to go above 25 miles an hour. If we mandated that no car could go more than 25 miles an hour, people would still drive in cars, but there would be almost no fatalities. And yet hundreds of people die in car crashes because we have determined as a society we want cars to take the vast majority of people where they want to go at the speeds they want to go, and we will live with the amount of death that occurs on the highways. And I wonder if, in the end, that's going to have to be the answer for the coronavirus. Or, Howard, do you see an alternative that gives you hope that there will be either a medication or a virus that will ultimately render the coronavirus no more dangerous than influenza?
I place my faith and my hope in development of a vaccine. I really believe that we've got the proper, ingenuity. What's really amazing, obviously there's a lot of similarities between this and the flu of 1918. People want to make that comparison. But the truth is, literally before before this outbreak extended even beyond China, they had a genetic sequence of the whole virus. So, I have to believe that there is some sequencing, some way that we can, develop a vaccination. And I think that will be a game changer. That's the game changer in my mind.
I hope you are right. And again, It's wonderful to hear the way you say it.
Yes.
Before we end, I want to ask a slightly it's not a medical question, but it is related.
Yes.
You live in Columbus, correct?
Correct.
There have been some references in the media, online, that there has been an expression of anti-Semitism in Columbus related to the coronavirus, suggesting that in some way this is, again, a Jewish conspiracy and a Jewish disease.
Right.
You're a member of the Jewish community in Columbus. What's it been like for you? What can you tell us about it?
So, we see these things, there is no doubt that in parts of rural Ohio, there is, anti-Semitism, look at the young lady that was killed in Charlottesville. The guy that killed her was a fellow from Toledo, Ohio. We've had other instances like that. So it's a good reminder for us that we can never feel too comfortable and it's not too far. And frankly, it's one of the things that I worry about, is that anytime there's an economic downturn, that anti-Semitism has an inverse relationship to that. So if the less the economy is doing well, the more anti-Semitism is likely to rear its ugly head. We've been pretty blessed. I mean, here we have a very, I think, an open community in Columbus. Maybe it's because, we have primarily white-collar work. We've got the state government here. We've got a university here. But we do see it, I think there were some images taken, frankly, from the protests that occurred outside of the State House. And by the way, I might mention that our health director, Amy Acton, does have some Jewish blood. I mean, I think her mother may have been Jewish. So that's a little bit more that adds to the fuel a little bit. So we're never going to escape that. But I think we just have to call it and speak out and make sure that it's never accepted.
Good for you. Good for you. By the way, have you experienced personally any anti-Semitism?
I personally have not. I shouldn't say not in Columbus, Ohio. So. You saw it somewhere else? Yeah, I as a kid growing up, I had some comments made, that were anti-Semitic. Where? When I was on a school bus once. But where? In New York? In New York, yes. Yeah. And by the way, that's very instructive as well. Everybody should hear you. Yeah. It's not like all of a sudden there's anti-Semitism. That anti-Semitism started in 2016. No. When you experienced, the only experience you had of anti-Semitism, you had as a kid in New York. Okay. Right. And what about at your hospital? Any anti-Semitism you've seen, heard, experienced at your hospital? No, because I will tell you, good or, that it's really a plus. I mean, our hospital has latched onto the notion of diversity, of having a diverse healthcare, workforce for a long time. So I think those kind of things would be frowned upon in our environment, thankfully. Well, I'm very happy to hear it. Yeah. Howard Werman, you are fabulous. It has been so lovely getting to know you. It is my hope that one day when this is all over, and I'll wait for you to tell me what it is, Howard, but when it's all over, in some way I can meet you in person and shake your hand. I hope we're still allowed to shake people's hands. I think you are. By the way, you understand the work you're doing is the most heroic, divine work any human being can do. You are on the front lines. You go into that hospital day after day after day to try to help people who are ill and who are frightened and who may face real horrible consequences from the COVID-19. And you go in there every day knowing that you then have to go home and be with your wife, and you do your level best to keep her safe. And you may have, it seems like you do have the antibodies, but you said the reality is we don't know how effective those antibodies would be, how long they last. No matter what, you and your colleagues are doing divine work. Every one of us appreciates you, thanks you from the bottom of our hearts, and you should understand how proud we are of all of you, and what an honor it has been for me personally to have this amount of time, and you let me ask any question I could, and you've been as honest and as gracious and as patient with me as possible. So I wish you only good health, you, your wife, your 4 children, your 8 grandchildren, all of the people you work with, your colleagues at the hospital. And I hope that you have called tu v'hatzlacha in your own personal life, all kinds of goodness and success. And I hope you'll let me come back to you as this thing unfolds if there are other questions I have. But I thank you so very, very much, Howard, for taking the time to be with us here on JBS. Thank you very, very much. Well, thank you for having me. I appreciate the opportunity to share my experience, and really I'm lucky because I get to work with real heroes. Dr. Howard Werman, a lovely man. I hope you learned something from hearing him.
So let's look at the rough coronavirus numbers for the last day of April. Here in the United States, there are now more than 1 million diagnosed cases of the coronavirus, with some 60,000 fatalities. But the recovery rate is up 5% over last week to 14%. As I'm sure you've seen, many states are planning to reopen society while maintaining certain precautions like social distancing and face masks. Meanwhile, in Israel, there are fewer than 16,000 diagnosed cases of the virus, a significantly lower rate of Israel's population than are diagnosed among the Americans here in our population, while the recovery rate in Israel has gone up another 17%, so that now over 50% of the number of diagnosed cases in Israel return to health, while the total number of deaths in Israel is just over 200 and is maintaining at 1%, over 20% less than the rate of death in the United States. So good for Israel. And finally, my reminder that if there's someone whom you like mentioned for a Mazel Tov on a Simcha, or in a Mishaberach list mentioning those who are ill and whom we hope will be blessed with Refuah Shlema, complete healing, or if you have a Yortzeit name and no synagogue setting in which it would be read, please send me those names, and I will be privileged to read them here on JBS. Any information may be sent to jbscommunity@jbstv.org. jbscommunity@jbstv.org. And if you'd like to be in touch with me directly, you can email me at rabbigalub@jbstv.org. My thanks as always to our director, Sloan Copeland. And until the next time, I'm Mark Golub. Stay safe and be well, my friends.